Hello again. In this workshop, we're going to be giving you some instructions for the use of the 3dEnergy gun in spinal percussion therapy, so more precise work on the spinal segments. So first tips, just some steps that we'll be taking. First thing, make your differential diagnosis of the spinal level and the percussion vectors that you'll be administering. So that's your clinical decision to make those choices. Turn on 3dEnergy gun. So we're going to press and hold the power button till the display lights turn on. Then we'll be setting our torque, clockwise or anti-clockwise. We've got 3 gears, so we'll choose which gear we wish to use and which direction we wish to use. Then we'll be determining our impulse speed. So we've got 6 gears, so we'll be deciding which particular speed that we'll be using on each particular impulse. So then we make our contacts. So the gun is already using all of its impulses, and then we apply the contact tip to the spinal contact point. So using the alignment of the gun body to suit your treatment vector that you've selected. Then holding that contact point for your preferred stimulation time. Again, that's your clinical decision as to how long you wish to stimulate for. So just some don'ts, some advice. Firstly, don't make contact before starting the preferred impulses. So don't place the dormant gun on the spine and then start to adjust your settings. Make your settings, then make your contact point. Don't change the speeds while maintaining contact. If you want to change something about the vectors, then I suggest you remove contact, change the settings, and then go back to your contact point. Don't increase the forces with your own physical pressure. This has all of the vectors built into it, so you don't have to increase the amount of pressure, the amount of force, how hard you're holding the gun. Don't overstimulate points. One thing you're going to find as you use this 3dEnergy gun, particularly with the torque and the impulse combined, it's very, very fast. The points will become diminished or completely vanished. And of course, don't ignore any normal contraindications to delivering this therapy. So that's your clinical decision making to determine whether this is appropriate or whether this isn't appropriate. So further to that, a disclaimer to all of these training videos. I'm not offering any medical diagnosis or recommendations in this workshop for how you should be treating anybody. I'm just giving you demonstrations as to treatment that you could administer when the correct diagnosis and differentials have been made. So it's assumed that you have the necessary qualifications, skills, indemnity to administer any of the treatments that are demonstrated here. If you choose to administer or to receive any of the following therapies, it's your responsibility to determine the appropriateness of this care. I can't assist you with that. I can't make those decisions for you. So some general principles. Choose your preferred lever arm. So we're talking in terms of vertebral spinal segments. Are you going to be using a spinous process contact? Are you going to be using a laminar or a little more laterally to a transverse process contact? I recommend for spinal work that you use the triangular head to get more specific contact point. So you've got 2 choices in terms of stimulation. You can contact a single point for a preferred time of stimulation, or you can lightly glide across or around a segment to stimulate that neurological level. Again, this is your clinical decision making as to which you believe will be the most impactful. So just some guidelines to understanding the following slides. So we'll be listing the spinal segment we're talking about. We'll be explaining the pattern of distortion that we're going to be stimulating. We'll recommend the vectors of stimulation. The images attempt to represent the treatment. So we have a 2D image with a 2D image of the 3D gun trying to represent and show you the contact points and the the vectors that will be used. So all of the slides following are showing right-sided patterns. So if you're actually dealing with left-sided patterns, all of the vectors will be adjusted accordingly. So this is a workshop. In the future, I'll be making short demonstration videos of each of these patterns on a volunteer, so you can actually see it in more of a three-dimensional live footage. So torque, are we going to use clockwise or anti-clockwise? The general principle used in most of these slides is I'm suggesting and demonstrating the torque which will open the joints on that side of the spine that you're stimulating. If you have an alternative method for differentially diagnosing the required torque, then please utilize those vectors. And as I said before, for left-sided patterns, you're going to reverse the torque described here for the right side. Our first segment, we're going to start at the top and work our way down. So we're going to show you two patterns for the occiput. So this is pattern number one. So the occiput is perceived to be translated laterally to the right, which is coupled with slight left lateral flexion of the occiput, or C1, to maintain a level head. So the contact point will be on the right side of the occiput. The impulse vector will be lateral to medial, right to left. And we'll be using clockwise torque to reduce that lateral flexion. So here's a 2D image of an occiput from an oblique view. So again, the 3D gun coming in obliquely, so it's straight lateral to medial, contacting you on your preferred point on the occiput, and you're going to be using right torque to reduce that opening of that occiput as it shifts laterally. So a second pattern of the occiput is an occiput which is perceived to be extended and slightly right lateral flexed at the occiput C1 junction. So again, contact point will be on the right side of the occiput, but this time the vector will be inferior to superior to reduce that dropping on the right side. And we'll be using anti-clockwise torque to try and open that right side of the occiput. That occiput again, so different vector with your 3dEnergy gun and the opposite torque to correct the different pattern that we're explaining here. So C1, so remember C1 doesn't have a spinous process, so we only really have the choice of one contact point. So C1 is perceived to be rotated posteriorly on the right, which is coupled with slight right lateral flexion of the C1, C2. Contact point will be on the right side of the C1 lamina or heading out towards the TP as you see fit. The impulse vector will be posterior to anterior to remove that posteriority. And we'll be using anti-clockwise torque to reduce that lateral flexion. So an oblique view of the upper cervical spine there, we've got our C1. So we're going to be contacting somewhere on that lamina towards the TP, which you feel is the most appropriate contact point. And we're using anti-clockwise torque to open that impingement. Now C2, so we've got two long levers. We've got the spinous process, or we've got the laminar transverse process. So this example is using the spinous contact. So again, C2 perceived to be rotated posteriorly on the right, which is coupled with some slight right lateral flexion of the C2-3. So its contact point will be on the left side of the C2SP to reduce that posteriority on the right side. Impulse vector will be lateral to medial, or left to right, and we're going to use anti-clockwise torque to open that right side. So looking from the left side in an oblique view, we come in onto the left side of the spinous process, and we're using anti-clockwise torque. So the C2 lamina or TP contact, it's the same pattern that we described before. This time the contact point's going to be on the right side of the C2 lamina or heading out on towards the TP. So this time the impulse vector will be posterior to anterior to remove that posteriority. Still, we're using the anticlockwise torque to reduce that lateral flexion. So oblique view again, looking from the right side, we're coming in obliquely, so it's straight posterior to anterior with your vector onto your contact point that you've selected on the lamina or heading out towards the TP using the anticlockwise torque. So C3 to C7 follows the same principles that we've just described for C2, so we won't labour on this again. So as I said before, if your differential diagnosis, like if you're sitting there saying, hang on a minute, when C2 goes posterior, it goes superior, that's fine. Then you need to make that clinical decision as to which is the most appropriate torque. So T1 to T12, similar principles again. So thoracic vertebrae is perceived to be rotated posteriorly on the right, which is coupled with the slight right lateral flexion. The contact point will be on the left side of the spinous again. Impulse vector lateral to medial, left to right, using the anti-clockwise torque to open up that impingement on the right side. So again, an oblique view from the left side. So we're on the left side of the spinous, coming lateral to medial, using anti-clockwise torque. So T1 to T12, following basically the same principles. So the thoracic vertebrae is perceived to be rotated posterior on the right, coupled with slight right lateral flexion. Contact point will be on the right side of the lamina or the TP. Impulse vector will be posterior to anterior, using the anti-clockwise torque to reduce that inferiority. So looking from the right side in an oblique view, so we're coming in straight posterior to anterior on our contact point. We're using anti-clockwise torque. For L1 to L5, all of these vertebrae follow the same basic principles. So perceived to be rotated posterior on the right, which is coupled with slight right lateral flexion. Contact point will be on the left side of the SP, spinous process, and we'll have a lateral to medial vector using anti-clockwise torque. Coming in lateral to medial onto the side of the spinous so that we're reducing the posteriority on the opposite side using anti-clockwise torque. So then our lamina or TP, or if you want to call it a mammillary process contact. So again, the vertebrae is rotated posteriorly on the right, coupled with slight right lateral flexion. Contact point will be on the right side of the lamina or the transverse process. Impulse vector is posterior to anterior, and we're using anti-clockwise torque to reduce the lateral flexion. Posterior to anterior to remove the posteriority with the anti-clockwise torque. So now our sacrum, again, we're going to show you two patterns similar to the occiput. So our first, the sacrum is perceived to be translated laterally to the right, with the pelvis almost rotating in its axis. So that it tends to be coupled with some slight right lateral flexion of the sacrum. So contact point will be chosen somewhere along the right side of the sacrum. Impulse vector will be lateral to medial or right to left. And again, we're using anti-clockwise torque to reduce that dropping on the right side. So another oblique view, we're coming in straight lateral to medial, and we're using anti-clockwise torque. So now a second pattern of our sacrum is related to nutation and counter-nutation of the pelvis, which has its pattern that happens in the sacrum. So the sacral apex is perceived to be dropping inferiorly. As the right ilium drops inferiorly, the sacrum drops on that side and rotates slightly anterior. The contact point will be underneath the sacrotuberous ligament. So we're using the sacrotuberous ligament as our long lever to impact the sacrum. And the vector will be inferior to superior now. And we're using anti-clockwise torque to reduce that slight torsioning, that nutation. So again, an oblique view, here's our sacrotuberous ligament. We're coming up underneath the sacrotuberous ligament to be able to lift and rotate that sacrum using anti-clockwise torque. In our ilium, again, we're talking nutation, counter nutation. As the ilium rotates posteriorly, it tends to impinge in medially, internal rotation. So the contact point's going to be underneath the PSIS. Vector is going to be inferior to superior and posterior to inferior to correct that rotation. We're going to use clockwise torque this time to open that sacroiliac joint. So coming in obliquely underneath the PSIS, using clockwise torque to remove that twisting of the pelvis. So just some notes to finish off. I've demonstrated single contact points. The precise contact point you use will depend on your clinical expertise and your differential diagnosis process. It's your clinical decision making as to how long you're going to stimulate the point, and it becomes your clinical choice as to whether you're holding the contact on one static point or if you're doing some sort of a gliding maneuver over a particular neurological level. So just some future workshops that will be coming up. We'll be doing video demonstrations of all of the contacts we've just demonstrated to you. I'll be describing to you what I call circling the sub, which is that variation of sliding around a segment and a neurological level. I'll show you the coccyx, the irregularities of working on the coccyx, as well as the cranials. And we'll give you some demonstrations as to just more generalized myofascial percussion therapy. So stay tuned. Look forward to seeing you soon.